All right, let's see what all we're going to do in this chapter. Pediatric emergency. It's kind of a long chapter. We'll take a couple breaks. We're going to look at developmental characteristics. We've been through these before, so we're going to go through them fairly quickly. We're going to look at parents and other care providers and relationships of those. Assessing a pediatric patient, special circumstances with pediatric patients, and I missed one. Pediatric medical emergencies, trauma emergencies, abuse and neglect, special challenges, and then EMT and pediatric emergencies. Sounds like a psychosocial thing too, doesn't it? Okay, y'all ready? Already got to start up here. Let's see what you remember. Now, if this were a regular semester, we would probably spend 2 nights going through this material. So you're going to be responsible for making sure you read this. Looks like you did. You did a good job on that exercise. I was surprised. Holding open. Newborn infant. We all in here. One more. Who missed that? Remember, the first 24 hours is called what? Newly born. The first 30 days is neonate. That's right. Okay. Just a little over 2/3 of you got that right. Okay. Newly born, the first 24 hours. Infants is birth to a year. Toddlers are considered 1 to 3. Preschool, 3 to 6. School age, 6 to 12. Adolescents, 12 to 18. So you do need to be familiar with these breakdowns because the characteristics are slightly different for each one. Okay, children and infants. Yep. Okay, the trachea is small and pliable. It's easily obstructed. Talked about all this already. The respiratory rate, if it is greater than 60, it doesn't allow them to completely fill their lungs. They're breathing too fast. Remember, what's the newborn normal respiratory rate for newborn? The range. Yeah, usually if you're bagging them 40 to 60, 30 to 50, it's going to be depending on what textbook you look in, but usually 40 to 60 at birth is what you're looking at. What's the heart rate usually at birth? 140 to 160. Do you see like a relationship there that can help you remember? I hope so. Okay, children have smaller blood volumes comparatively, but they may not become hypotensive until they've lost 30% of their blood volume because they compensate. We've talked about that. They compensate because why? They're healthy. We're not. They use oxygen and glucose at a rate 2 to 3 times faster. Their metabolism is faster. They are always moving. I look out here and you guys have almost turned to stone. I can see your eyes glassing over. How much oxygen and glucose are you burning? Not very much. See little kids still, you know you have a problem, right? They're more prone to developing hypoglycemia and hypothermia. Hypoglycemia because oftentimes when they get a little bit older, they're so busy running, they're not going to stop and eat. Yes?
The greater than 60, does that apply to all pediatrics, or are you just saying you would know?
Well, greater than 60 for all human beings is always bad. But certainly with the little, well, I mean, if you have an adult breathing greater than 60, you're bagging that person. They're going to be intubated. So anybody more than 60. But just be aware that kids often breathe faster, but make sure that you count it out because 40 might be within normal limits. You know, 50 might be okay. They get up to 60 and they're not going to be able to adequately fill their lungs. Does that answer your question? Not really.
Well, it's pediatric differences, so.
Are you still looking for that point?
No.
Is that where we're going here?
Yeah, that's right. No. I think I kind of got it.
Okay. It's not that big, I mean, really, because anybody breathing that fast is never good. But kids normally breathe fast anyway. And if you think about what 60 is, that's in and out in 1 second. It's pretty fast. But it's easy to overlook. Pediatric patients, hypoglycemia because they never stop. They may not eat enough. They don't eat well sometimes. Hypothermia because they don't thermoregulate. They don't start getting good at that until they're, 2 years or older. Head, we talked about the head. Here, remember, I think we had this picture earlier. See the difference in the airway? This is almost straight. This has a curve going north. You know, it's more anterior where it ends. And so if you tip that head back, you're going to close that off. That's why we leave it in a neutral alignment. The mouth and nose is smaller, yeah. Their tongue is much larger comparatively. I mean, for the space that it's in, it takes up a lot of area in there. So if it swells for whatever reason, or you get some object caught in there, it really interferes with their breathing. Airway structure is more easily obstructed. Cricoid cartilage is less developed and more less rigid. Trachea is narrower. Yeah, all that kind of stuff. Newborns and infants, obligate nose breathers. The epiglottis is much higher in the airway than an adult. So when you're looking at it down the road, if you're going through paramedic school and you're trying to visualize it, it's like right there in your face. Oh, forgot to tell you, there's a little star. I didn't have a star there. Hypertension will not develop until greater than how much blood volume is lost. Well, it usually doesn't develop. Who put 10%? We just had this. 30%. Okay, cardiovascular system. This is important stuff. Bradycardia is a late sign of hypoxia. What this means is when they're hypoxic, their response to that is going to be bradycardia. Once they become bradycardic, you know, they're going to compensate. Once they become bradycardic, they're falling off the cliff. So that's why we don't bother with checking their pulse, because it doesn't matter. They're going to compensate, and then they're going to fall off the cliff. So bradycardia is their response, really, to hypoxia. Newborns, bradycardia is the initial response to hypoxia. So there's a little bit of difference here. Right at birth, if they're bradycardic, they're very hypoxic. And there's some other issues going on there you'll understand if you go on in the program. Just as I talked about, as the baby goes through the birth canal, all the little squeezing of the lungs and all that stuff that transpires causes some of this to occur. So in newborn, bradycardia is going to be an early sign of hypoxia. For a little bit older child, infants and children, bradycardia is going to be a late sign. They're going to be compensating. The newborn doesn't compensate. It just goes right to bradycardia. So that's why, think about it. Now see, if you'd put this as one of your choices and I ask you why is that important, what would you tell me? Okay, think about when we start CPR. Do you remember from the CPR? We start CPR anytime the pulse rate is below 60, right? If it's below 60, we're doing CPR. They're bradycardic. They're fixing to die. So if it's between 60 and 80 and we're ventilating, because see, right here, hypoxia, if we correct hypoxia, their pulse rate should return. It's not always the case for adults, but for kids, most of the time, their problem is going to be hypoxia. Between 0 and about 2, it's a hypoxia issue, an airway issue. You're going to see scenarios on National Registry, and it's going to be based around hypoxia and respiratory problems for pediatric patients. It may be a trauma that caused it, you know, the precipitating factor, but ultimately you're looking at hypoxia. Hypotension will not develop until 30% of blood losses, till 30% of blood volume is lost. They compensate. And that's important when you're doing your assessments. Those kids will look great. I've seen them. They come into the ER and they look great. They've fallen down the steps. Doesn't matter. They look great. They're talking and laughing. And then, lo and behold, they become bradycardic and they just circle the drain right in front of your eyes because they've had internal bleeding. They're not perfusing, not getting oxygen around. Okay, chest and abdomen, we already said this, they're abdominal breathers. Those muscles are a little bit stronger than their chest muscles, so they don't have the ability to really expand their chest to increase their respiratory volume. They're going to move their abdomens when they're really little. As they get older, that goes away. Their abdominal organs, they don't have the musculature of protection or layers of fat like we do typically. So they run much greater risk of injuring their abdominal organs. And we mentioned the liver and the spleen. They hang just below the rib cage. And that's a big deal because they can bleed to death very quickly and you won't even know it. Most of the kids that compensate and look so good and then they circle and die, more times than not, it's abdominal injuries. They've injured and they've got internal bleeding in the abdomen. So it kind of goes undiscovered. It's terrible. The ribs are pliable. They also are more horizontal. Ours kind of slant up like this. Theirs are more horizontal. I know about the pliable point. I don't know why it's important that it's horizontal. Their lung tissue is much more fragile, more easily injured. So, you know, if they get that collapsing of the rib cage springs back, but it's done internal damage in there. Normal for abdomen to move with inhalation, abdominal breathers. Chest muscles are used as accessory muscles. Do you understand the significance of that statement? Significance. Yeah? What is it? Yeah, as an adult, what accessory muscles are you looking for? If an adult's having trouble breathing, you're going to see it through here. These are the accessory muscles that you normally see moving. For kids, their accessory muscles that you see are going to be their rib cage as they're working hard to breathe. You may see retractions around the rib cage, but for us, that would be normal. Does that make sense? Body surface. It's larger than an adult's in proportion to their body mass. They lose a lot of heat through their skin because of that. So they're more vulnerable to hyperthermia. They're also more vulnerable to hyperthermia for much of the same reason. Oops, did I have a star there? I didn't do a very good job. Okay. A baby's head equals how much according to the rule of nines? Let's see what you remember. Pretty much getting on that. One more. You know what? We're going to get out early tonight because y'all all got that right. We're just not getting out yet, but we'll get out early. How's that? Good job. And metabolic rate is much faster even when they're sitting and trying to rest. You know, everything's still moving in there. More at risk of acute hypoglycemia. Oops, gee, I didn't get any stars in there. Average blood volume of newborn. Somebody gave that away during our early quiz. Two more, come on, one more. Chop, chop. Well, some listened, some didn't. Newborn, 12 ounces, about the size of a Coke can. Got that one, huh? Let's see, who put a liter? Holy cow!
I just put something.
Think about that liter bag. Did we look at a liter bag down there? It's about the size of a newborn. Here we go. 9-pound newborn. Whew, that hurts. About 12 ounces. A kid, 60 pound, 4, 5, 6-year-old, 2-liter bottle. An adult, 125 pound, 2-liter bottle. It's not very much, is it? Seems like it should be more, but hey, it's moving around. Psychosocial personality characteristics. We're going through here quickly. What techniques would you utilize when attempting to assess a crying infant?
Put them in a position of comfort.
Make them comfortable. Yeah, let them sit with mom or dad. Maybe you can calm them down that way. Okay. Make sure you tell them who you are. Tell them what's going on. If no life threats, just keep everything calm and do your evaluation. Unless you do a good assessment, you're not going to treat appropriately. With a child, say, with a traumatic injury, what specifically are you going to be looking at? 3 initials. Huh? With a traumatic injury, what? Mechanism of injury. With the kid, you may not see anything on their body. Their ribs don't break. They may squeeze all the way down and touch themselves inside and spring back. And you would have no idea that they could have damaged everything in that chest cavity. However, if you're looking at mechanism of injury, they fell off of a 2-story porch. Mechanism of injury, I don't care how good they look. You're going to assume that they're badly injured. If they're playing nicely, give them a little toy, keep them occupied. Kneel down so you're not hovering over them. Yeah, that was one, but it didn't count. Just because it's in the book didn't mean it count. I didn't want you to recite the book. Get down on their level so that you won't frighten them. Same as you do for a little granny, You don't want some giant hovering over them. You want to get down on their level so that they feel comfortable. Smile, make sure they can see you, make eye contact with them. Kind of start at the bottom and work your way up. You know, if you just go up and all of a sudden you want to like play with their ear or something, you're going to freak them out. So start with, what's the little game with the feet? This little piggy? I know everybody knows that one. I see y'all playing it sometimes. This little piggy, sure. Don't use equipment without first explaining what you're doing with it. I know you've all seen it. Like, take your stethoscope. They love to listen to themselves. I mean, I had the two little girls across the street over this morning. They're 4 and 6. So we play with the stethoscope, you know, put it in their ears, and they listen, you know, listen to the dolly, you know, they listen to themselves, they listen to mom, and then they let you listen. So if you have the time to do that, make sure you explain what you're doing and use it as a teachable moment if you have the time. But you get a lot better compliance that way. Stop occasionally and find out if they understand. You know, the older they get, they can understand some concepts. So don't tell them more than they need to know, but try to keep it interesting for them. Don't ever lie to them. They know. One other thing I want to mention here is don't promise something or give a choice to a child that you're not able to fulfill. Like, you know what? If you don't let me listen to your lungs, then I'm going to leave. Guess what? Bye. See ya. So that's not an option. So give them a choice. Kids love choices, even as they get older. You know, you guys like choices. You know, we're either going to do this or we're going to do that. So give them two choices that you're good with either way, where you know you both benefit there. So don't say, if you don't do this, then I'm going to do that, because if you don't do it, they're never going to believe you again. Kind of like students. Okay, here's just an example of some blow-by. See, they got a little paper cup. You can just stick that little tubing right through the bottom of that paper cup. Now it's something fun. They've made little teddy bears and different little animals where you can actually attach the tubing to that, and they can hold the little bear, and you say, hold it close to your face, and it'll be you know, giving some blow-by oxygen. So that's kind of handy. So consider different ways. I worked with a guy that would blow up our gloves, our latex gloves. He would blow those up and he'd draw on it, and he could actually put the tubing through the fingers because it'd be real tight in there. So whatever, they were pretty geeky, but kids always liked it. Parents are going to act differently when their child is injured or hurt or sick. Some may be calm, some are freaking out, some blame themselves, some blame you. So just be prepared for all types of responses to parents. You know, sometimes they feel guilty if it's a traumatic injury. They feel guilty that, you know, they've done something or they didn't do something. So just be prepared for that. And sometimes their reaction can interfere with you providing care for your patient. I'm going to relate to you a quick experience I had, just so that you'll never have to deal with this. I had a patient, I think I told you about this little kid. He fell off a second floor balcony, and, you know, mechanism of injury. He looked okay. We put him in a KED. You know, he was alert and oriented. He was carrying on talking to his dad. So we transported the child, and I let the dad ride in the back. Did I already tell you guys this? I let the dad ride in the back. We had a long transport. We're out in Fort Morgan all the way out in like Timbuktu. So we got about halfway there, and the child went unresponsive. I mean, I'm looking at him, we're playing, and all of a sudden it's like gone. And I couldn't wake that kid up. So now I'm thinking, ooh, my kid has just circled the drain like this. And the dad started freaking out. I mean, he's grabbing me, do something, do something. And I'm going like, I can't do anything, like you're grabbing me. And so we had to actually pull over. When I should have been taking care of the child, we had to pull over and put the father in the front seat because he just wouldn't stop. So it was a problem. So you got to think about that as a possibility. So if the child is okay being separated, I'm okay with moving that parent somewhere else. But if they need to console them, then okay. But make sure you tell that parent, you know, that he's got to cooperate, you're taking care of the child. And sometimes you have to be quite firm. It got kind of ugly that day.
Did he die?
No, but we ended up calling the helicopter, and we met it. It was not far. They had just canceled off a call, so we actually met the helicopter, and they took him to USA, the trauma center, And I think he just fell asleep. You know, it was late at night. He'd probably been up late, and I think he just fell. You've seen kids that you just almost can't wake up because they're so asleep. I think he just fell asleep. But we couldn't wake him up. I didn't know. Well, you can't tell that he wasn't bleeding in the brain or whatever. He fell from a 2-story balcony onto cement, so he was lucky. Ask for help. If you can have them, you're going to get a better response if the parent can console them, and you can get information from the parent also. Okay, assessing the pediatric parent. Okay, sorry, I didn't put any stars in here. Bad for me. The first leg of the pediatric assessment triangle. Let's see if you read. 2 more. Make a guess. I won't expose you. Its appearance, and we're going to talk about the pediatric assessment triangle, I think, at length. Pretty good. Which one's appearance? And what are we looking for? What do they look like, and how are they interacting? That's what we're looking for. What's here? Work of breathing. That's how hard. Are you seeing retractions? Are you seeing abdominal motion? You know, are you seeing nasal flaring? So how hard are they working to breathe? And the last one? Now this is not blood pressure, it's circulation to the skin. And what do I call that? Skin signs. Skin signs. All of this you're going to do before you touch the patient. This is what you do. You walk into the room, he's across the room. These are the 3 things you're doing. Is he moving around? Is he active? Is he interactive? Does he look at you? Work of breathing. You know, you see this seesaw breathing. Do you hear wheezing? And then circulation to the skin. What's his color like? You look at them, do they look really pale? You know, they look normal? That kind of thing. The pediatric assessment triangle. And you'll rely on this. You know that when you see a child, most of you have seen kids from time to time. I mean, I can do it with you guys. You look at them, you can look at them pretty quickly and go, good or bad, right? First thing you're looking for is what do they look like. You know, are they moving? Are they making eye contact? Then you're looking at, are they breathing okay? Do they look like they're under any distress? Last one is, what's their color like? So, you know, that night when we almost lost up here on the front, she just looked like crap. Yeah, you just looked like sky tile that night. How's that? You know, they just look bad. And that's really what this pediatric assessment triangle is. And I'm not trying to say you were a child.
No,
here,
I
but
know.
you know, you see the color just drains from their face, and they just look bad. They're not interacting. They're not looking at you. Appearance, work of breathing, and circulation to the skin. You will very likely see this on National Registry. They have a pool of many, many thousands of questions that they'll be pulling from. So all of you are going to get different tests. I know this material is in the test bank. Whether you actually pull one or not will depend, but there's a good chance you could pull this. So you need to know what these things are. You need to know the order. You need to know what they're called and what you're looking for. Okay, when you're doing your assessment, you're looking if the child is reacting normally for his age. For example, would you expect a 1-month-old to make eye contact when you walk in the room? Not so much. Would you expect a 4-year-old to make eye contact normally? Yeah, they're scared. They're going to look at you. You know, they're trying to figure you out. So that's going to be based on their age, normal behavior for their age. Do they move around spontaneously, or are they lethargic? If you don't know lethargic, that's a word you need to be familiar with because you'll see it. So if you walk in the room and they're just laying, not even moving, and they're kind of staring off at the ceiling and they don't make eye contact with you, what's the appearance like? Yeah, that's bad. Each one of these, good or bad, good or bad, good or bad. That's all you're looking for here. Do they appear attentive and recognize the caregivers? You know, there are times where they don't know where they are. You know, they don't know who the mom is. You know, if you can walk over and take a child from the mother's arms, what do you think about this? There's a problem somewhere if that kid allows mom to hand you over. they have no level of consciousness pretty much then. Do they maintain any eye contact? You know, it's just like adults. Once they get to a point where all they can think about is how they're going to stay alive, they're not worrying about making eye contact with you. They're busy with other important things. Are they easily consoled or seem inconsolable? You know, if they're just screaming and can't be consoled, that's not a good sign either. Usually the caregivers can console the child most of the time. Now, what if they're not screaming at all? One thing do we definitely know if a child is screaming and crying? Yes, ma'am. They've got a good airway. They're not unconscious. They've got a good level of consciousness, right? So kids that are screaming, if I walk in the house and a kid's screaming, that's always a good sign. They respond to the parent or caregiver by calling them. Or respond appropriately, or they don't respond at all. You know, so if the parent's saying, Johnny, Johnny, and the kid's just off in the ozone somewhere like usual probably, but in a sick experience, if they're not responding, that's not good either. Scene size up, scene safety. Okay. This pediatric assessment triangle allows you to very quickly identify a critical patient from a more stable patient. Now we do know that kids will compensate much longer, so they may initially look okay, but for the minute when you look at them, you can if they're a critical patient, then they are like doing very badly, right? So if they're not making eye contact, if they're not moving, if they're not responding, then you know you have a problem. So this pediatric assessment of triangle really is helping you form your general impression. You know, you look at them, they look good, then they're probably good. They look bad, they're probably bad. They're probably bad. Okay, so you're looking for pretty much the AVPU scale here too. Are they alert? Are they verbal? If you have to shake them in order to get a response, it's still going to be the AVPU scale. Oh, I got a question here. Number one cause of death for children.
If everybody goes
Yeah, y'all missed this one. Of course, it does say car accidents, right? Could be other trauma too, but yeah, hypoxia is the big issue here. Your book may not have really spelled that out, but the bottom line, most of the time, it's going to be hypoxia across all the pediatric age groups. Okay, airway assessment. You're going to see this repeatedly because it's on registry. What have we got here? Make sure you count their respirations for 30 to 60 seconds, which of course that's the same amount we do for an adult. But 30 seconds usually is going to do it for you. How many times should they be breathing in 30 seconds? Yeah, it's going to be a range there, but probably about 12 to 20 in 30 seconds, so you double that. And it's going to vary according to what their age is, and then really the books are a little bit different. But as the smaller and younger they are, the more rapidly they're going to breathe. So you got to expect it and look for it. Any cessation of breathing longer than 10 seconds is abnormal. Remember I said earlier that most people breathe regularly. You know, it's unusual to breathe irregularly. Now you can breathe fast or slow, but for it to be irregular is very unusual. If they're breathing irregularly, then you're looking at a neurological problem of some sort, which would be hypoxia if it's because of lack of oxygen to the brain. But if they're breathing rapidly or if they're breathing noisily, all these are going to indicate some respiratory problems. Oop, another question. Come on, one more. Somebody wake up. Who do we need to wake up? We got everybody? All right, somebody to vote. Yes. So 5 and under is going to be the age. I know I probably could have worded that differently. 5 and under is going to be the age range where you can usually depend on it being accurate. When would it not be accurate? When they're cold, that's right, because, yep, they vasoconstrict. Okay, circulatory assessment. You're going to assess their pulse rate and the strength of their pulse. Now, we are assessing here at the radial artery, so what do we know about this child? Yeah, I wasn't going there, but that's...
They're older or something?
Yep, it's older. So remember, we check the brachial pulse for who? Babies, yeah. So that would be infants. B, brachial, babies, yeah. All right, good work. Check the capillary refill on these little guys. Don't forget. And, you know, we really haven't stressed that like we should have in the labs. I have to try to remember that. You need to check a capillary refill on your patients, even your adult patients. It's still going to tell you something. If you've got a 40-year-old and you check their capillary refill, it takes 5 seconds. That's never normal. Okay? You know, if it's 3, I might think, well, they're not circulating well. If it's 5, it's not good. If you check it and it's 2, I know that's good. Okay? Sort of, kind of. Sometimes you may check the peripheral pulses and the central pulses. When we say central pulses, what are we talking about? The femoral or the carotid. Those are going to be your central pulses that you may check. Everything else will be peripheral. Are they warm? What's their color like? What are their skin signs? That's what we're looking for. What's the skin condition? What does it look like? What color is it? What's its temperature? Those are all skin signs. You want to get all of those. With kids, you also want to check their urinary output. Okay? Why is that significant? Anybody have any ideas? Dehydration is a really big deal. And you may not recognize it. They may just be lethargic, which could be from anything. But if you ask the mom, well, how many dry diapers have you changed? Or how many times have you had to change your diaper today? Have they been wet? And I will say that lately the diapers are such that you almost can't tell they've peed, which can be a problem. But ask them, you know, do you feel like they've been urinating normally? Have you changed the same number of diapers as you usually do? Because if they've got decreased urinary output, then you're looking at dehydration, very likely. Check their mental status. Big, big deal. Okay, you're going to make your transport decision based on the results of the primary assessment. And that's also going to factor this in. This really is going to be your general impression. But this is going to tell you pretty quickly if this is going to be a rapid transport or not. But you still got to do your ABCs. Okay, your secondary assessment. Whoops. At which age do we begin taking a blood pressure? I'll get this one. Somebody's little, oh, there we go. Okay, I want to know who picked 6.
That was my fault. I meant to press C. I really
Yeah?
did.
Well, there's probably 2 of you that picked that.
Okay, well, I didn't just press it.
You picked it twice?
When I looked down, I was like,
Okay. We know that at what age do we not do it? Up to 3. So above 3 would be 4. Oops, what happened? It didn't mark it, my fault. Okay, when you're doing your exam, it usually works better if you start at the bottom or at the chest if they're a little bit older and work your way up towards the head. If you can, allow the mom to hold them. If that's, if they're too bad off, then we're not going there. If the child is conscious and alert and you stress them out, it's nicer if the caregiver can hold the child. If not, it's like, get out of the way. If you've got a patient that's fixing a code, then all bets are off. Try to protect the child's modesty. Here it says child. If they're 1-year-old, it's not a problem. As they get older, it becomes more of a problem. So be careful about that. Try to keep them covered up. Tell them what you're doing, that kind of thing. Tell them why you have to remove it. If you got to take their shirt off, and really this is for all ages. If you've got a patient that's never been in the back of the ambulance, they have absolutely no medical training at all, and you start pulling their shirt off, if they don't know that you want to listen to their lungs or you need to palpate. So anytime you touch a patient, you need to tell them why you're going to touch them and where you're going to touch them so you don't freak them out. They're probably already freaked out. So it's important that you always talk to your patient so they know what to expect. I just didn't put any stars in here. Which can cause a bulging fontanelle? One more? Somebody's clicker's not working good here. Meningitis. Fever doesn't typically cause that, but meningitis definitely will. Some inflammation, you're going to have swelling there. You're doing the physical exam, don't mash in on the soft spot. Just because you know what it is, don't give it a big mash, okay? Meningitis and head trauma both can cause the fontanelles to bulge. Head trauma because why? Swelling, bleeding in the brain. Meningitis for essentially the same reason but a medical cause. A sunken fontanelle is going to scream dehydration to you. So you look at that little baby, you know, that skinny little head, no hair on there, and you see that little depression, then you've got a kid that's probably dehydrated. Nose and ears, neck, they are vulnerable because of that big old head, right? The muscles are less well developed, you know, the neck muscles, so it's harder for them to hold that big old head up. However, when you're examining the neck, if you're looking at meningitis, then you may see that the neck is sore. It may be very stiff. If they're unconscious and they have meningitis, there's a good chance that neck is still stiff. It's not like they're holding it stiff because it hurts, which will be part of it. But even when they're unconscious, the neck is not going to be supple. It's not going to move. Airway, chest. You want to be alert for airway sounds. You know, kids that are under distress, very frequently you'll notice they have nasal flaring. They're like really open their nostrils up. But they may also grunt. Remember we talked about grunting earlier in the semester. Grunting is a form of what we call PEEP. P-E-E-P, positive end expiratory pressure. It basically works the way CPAP does, where you're kind of keeping air in there. Well, when they grunt like that, it's forcing back pressure in there, and it tends to open up and keep those alveoli open. So grunting is a means of keeping air in the chest and forcing air through the alveoli. So grunting while it's unconscious, children will do that frequently. So grunting indicates respiratory distress, but when they stop doing it, it's kind of like wheezing is bad for an asthmatic, whereas not wheezing is even worse for an asthmatic. That means that they're not moving any air anymore. So if you got a child that was grunting and now they're not, it's a good chance they're getting worse rather than getting better. Does that make sense? Watch for equal rise and fall. Look for any bruising to the chest. Remember we talked about their ribs are so compliant and so basically soft that they can go in, completely crush the chest and spring back out like nothing happened with no breakage. But they may have bruising if it's, you know, if it's been a little bit of time. So they may bruise. So make sure you look for bruising. Check for any paradoxical motion or any retractions through there. It's unlikely, but can it happen? It's just like, I never thought I'd see a child with a femur fracture. Well, I ran a 2-year-old with a femur fracture. I was like, whoa, I didn't even know that thing could break like that. You know, with the right force, it can happen. So make sure you check for it. Abdomen, you want to note if it's rigid. If it's rigid, what's that telling you? Internal bleeding, absolutely. Check to see if it's distended or if there's any discoloration around there. Discoloration, of course, would be bruising, right? If they have a lot of blood in the abdomen, then it's going to interfere with their breathing. The diaphragm's not going to move well. Their muscles are already taut, so they're not going to have that flexibility. So, excuse me, having a lot of blood in the abdomen is going to interfere with their breathing. Check the pelvis for stability, just as we do with any other patients. Get in the habit of checking for a capillary refill. You know, the other day when we were going through our assessments on vital signs, I was surprised. You got the regular things. You got blood pressure, pulse, and respiratory rate. But there are a lot of other things you need to check. What else do you need to check? Their O2 sat. I think we went through almost everybody in here before one person, I can't remember who it was, finally checked an O2 saturation. It really surprised me. So what else are you going to check? Check their pupils. I don't care if it's a trauma or if it's a medical, you need to get in the habit of checking pupils. You may have a drug user that you're seeing there for something completely different, but you need to know if they're on narcotics or on stimulants or something. So get in the habit of always checking their pupils. What else you need to check? Yeah, we're probably not going to check their temperature per se. We're going to check skin signs. Are they warm or cold? What else? Think of anything? Yeah, check a blood sugar. You know, your medical patients, you just need to check a blood sugar because so many things can present and it's directly related to blood sugar. What?
When we were at the emergency room this weekend,
Yes.
a guy had a glucose level of over 8,000.
Over 1,000. It
And he
showed
was
on there?
Skinny little guy.
Mm.
He came in and they diagnosed him with diabetes, and they didn't know he had it before. He
Oh,
said he
yeah.
had a headache and was feeling really bad.
Yeah, if you go back and start asking him all his signs and symptoms, I mean, he probably never noticed them. Yeah, do you urinate a lot? Yeah, do you drink a lot of foods?
Yeah. I asked him because she told me to go in there and do an assessment and vital signs on everyone, and not really a minute too soon before she called me out. But I was like, you been urinating a lot? Yep. You always hungry? Yeah.
Yeah.
And
There
he
you go.
was type 2.
Type
which
2,
is
how old was he?
weird. Like,
19.
yeah, 19 or 20. And he was skinny.
And they said type 2?
Yes, because no DKA.
Yeah.
He's got a DKA.
You had a DKA? How did he present?
It was huge. But when I got there, they had monitored him for like 8 hours in the ER. So it was like early morning when they come in. The nurse was monitoring him up and his blood sugar. They had been on insulin drip, and even then his blood sugar was still like 650. It took 3 hours for it to get down before they could send him to a
Well, you know, if you give them too much insulin, you're going to kill them, and there's no take backs. It happens very quickly. So they have to, it's a very delicate process of getting the insulin just right. So, and that's something you have to look for with your pediatric patients. If they have a diagnosis that when they're first diagnosed with type 1 diabetes, they're trying to regulate their insulin, they're going to get a lot of spikes. They're going to be very brittle. So those are very commonly your patients. You know, you start asking questions, and they're going to say, yeah, well, he's just started taking insulin. Well, if he's unresponsive, probably, you know, it was a little on the high side. And then as they grow, their needs change. So they have to be constantly reevaluated. So it would not be at all unusual for you to get a diabetic emergency in a pediatric, and not just the initial onset, but even though they're already diagnosed and under treatment. So yeah, there's a whole host of vital signs that are not just, you know, blood pressure, pulse, and respiration that you need to get in the habit of always checking. And you know, capillary refill is one too, and it's one that I forget. So don't forget. Absolutely. Any unresponsive patient's getting a blood glucose check. It's just going to happen. They're unresponsive, altered mental status. You're checking their pupils. So those are the things you need to just spring into your mind right away. Okay, extremities, you're checking your distal pulses. You know, you're going to check up here. You're going to check at the feet. If there's a disparity there, that may indicate they've got some blood pressure issues. You know, they may be hypovolemic or something. Check your PMS. Get in the habit of always doing that by 4. I noticed that when y'all were doing your assessments, lots of times you didn't check a distal pulse. You're checking pulse, motor, and sensory in every extremity. Gotta get in the habit of doing it. Mental status. Mental status is a big indicator for a pediatric patient. Make sure the airway's open, monitor their breathing, check their pulse. Skin signs, reassess, and reassess. And they're going to look like this, right? They're going to be really boring, until what happens? Yeah, and once they take that turn, if you're still pre-hospital, it's not probably going to be a good outcome. Special concerns, how far are we? I can't read it on my little sheet. Does anybody know how far we are? What time is it? Oh, let's take a break. We'll stop right here. Y'all run out for a couple minutes. right, maintain an open airway.
Hey, there's the.
You know this. With kids, remember, you're doing a neutral alignment. Don't tip it back real far. If they've got trauma, you're still going to do a jaw thrust. Make sure you suction. Watch for the tongue. If they're unconscious, if they don't have a gag reflex, make sure you put in that oral airway because that tongue is so big that if you try to bag them, it's just going to roll back in there and block the airway. Oops, see? Got a question right there. Didn't even realize it. What is the ventilation rate for a 6-month-old baby? Let's see. Let's see. Sort this out. One more. Take a stab at it. All over the place. Okay, what do we know about 6 to 8?
No, that's terrible.
Yeah, that's too slow for you. 12 to 20 is what? That's adult, yeah. So now we've got this. 20 to 30 for 6-month-old or 30 to 40. So let's see, that's almost 80% of you. You got, where's my thing? Yeah, no, I know. It's because the program is supposed to be on C, 20 to 30. Who breathes 30 to 40? Newborns, pretty much. You breathe 30 to 40?
Oh, no, I thought you said who guessed it.
Oh.
Yeah, I get it.
Yeah, well, that's one, it's kind of it's probably one of the best questions, but 20 to 30 for kids is kind of your good range on there. For a 6-month-old, I'm probably going to go on the real high side of that. OPA, with the OPA with a child, if you can use a tongue depressor, it's usually going to be about the best. If you don't have a tongue depressor, how are you going to do it? You're not going to put it in just the way we do with an adult where you go like this and rotate it over. You need to use the tongue depressor and go curve in or else come in from the side and then just put it down. You don't want to do it reversed and over because that tongue is so big you're never going to get the fat curve part beyond it. With an adult, you've got so much more space in there you can do that reverse, but on a child it's not going to work for you. The NPA, who's doing your airway station? Steve? Okay. Did he talk to you about, the flange, that it goes towards the septum, and how some of them are pre-curved, and some you have to start upside down, and some you start right side up? Did y'all look at that? Y'all kind of going, yeah, kind of not so much. Either way, however it is, whichever, if you go in the left nostril, the right nostril will depend on whether it's curved up or curved down. So just make sure you've got the bevel to the septum, then you'll be okay. It's important that you measure it right because if this goes too far, you may actually put it in the esophagus right here. That's what you don't want. So if you slide it in, this is the dummy place. You can see that this curvature, because this is so anterior, you can see how hard that curve is there. So you're not going to hit that. If this thing is too long, it's going to go into the esophagus. You can see that with the oral airway, if it's too big and it's too long, it's going to land right in here and it's going to block the airway. You just want it to come long enough to hold the tongue. You don't want it to get down in here. Clearing the airway. If you have a partial airway obstruction, and I want to make this point because you may get a scenario like this on National Registry. If it's a partial airway obstruction, if they're moving air enough that you think they're going to be okay for a little while, you want to leave well enough alone. If you start doing the Heimlich or trying to clear the airway and that object moves down and completely occludes the airway, now what? Yeah, it's gotten a lot worse. So sometimes you want to leave well enough alone. So if it's a partial obstruction, put them however they're most comfortable. Give them some oxygen, keep them calm, and transport them. If it's a complete airway obstruction, then you need to go through your airway clearing maneuvers. And all of those are in that CPR book that I can tell you right now, on your final exam, you're going to have 25 CPR questions. Even if there's only 25 questions on the exam, 25 of them are going to be CPR. So make sure you read that because it's so important. Okay, with the little kid, this is under 1 year of age. If they're conscious, this is how we're clearing the airway. Is it going to give us more? You're going to do back blows and chest thrusts. Back blows and chest thrusts. Once their airway clears, you're going to know it because they're going to do what? Scream their heads off. So as soon as that airway clears, they're going to start breathing and they're going to start screaming. If they go unconscious, now we're going to have to do it, but you're going to have to check their airway and ventilate in between. So make sure you read that process. If they've got an airway obstruction, when I say we're doing chest thrusts, it's CPR. That's what you're doing. You're basically doing CPR chest compressions. If you have to put a mask over a baby's face, because of there's not much nose to support it here, the mask is going to cover this area from between the eyes down to the chin. Mask doesn't go under the chin. Aha, look what I have here. What's the ventilation rate for a 6-year-old? I guess this one's probably going to do the same thing too. 3 of you people need to wake up. One more. Good. Is a 6-year-old an adult or a child? They're a child, okay. Just checking. That's supposed to be on C. C should be up there. I'll have to remember to fix that. Ventilation rates. Make sure you don't breathe in too much volume when you're ventilating with a face mask or if you're ventilating with a BVM. Remember I told you early on that the BVMs and the masks are interchangeable. So if you had a very small adult, you could use an adult mask with a child-sized BVM and vice versa. But it's better if you have those that fit one another. Ventilation rates, 12 to 20 or every 3 to 5 seconds for an infant or child up to puberty. That goes against what I just said, huh? All right. Well, these are ventilation rates. Breathing rates are different than ventilation rates. We're going to pull out our book and make sure we get it right. Sorry, guys. Your chart says 12 to 20? Well, see, then maybe I was right on there. They breathe faster than that, but when you ventilate, it's just like with all of our patients, when we ventilate less than they normally breathe, right? And why is that? Yeah, you don't want to over-ventilate them, particularly if you're doing CPR. Less ventilations is more, really. 10 to 12 times per minute, every 5 to 6 seconds if the child has reached puberty. So here at puberty, we're talking about the adult rate. Now, even as adults, our normal rate is 12 to 20, but when you're ventilating, it's going to be less. So here, when you're ventilating, you're going to be less. So the respiratory rate is going to be higher, the ventilation rate is going to be less. Okay, if you're providing, let's see what you remember. I'm pretty sure I told you guys this. One more. Well, that's all over the board. Does anybody want to reconsider theirs? Who all thinks it's B? Who thinks it's C? Who thinks it's D? Y'all voting with a majority? I know this one's right. Okay, let's go over the formula.
Well, now the book actually says 105.
I don't care what it says. I'm giving you the formula.
This is my code.
Okay, do you remember the formula? Normal is going to be 80 plus 2 times the age in years. So if he's 6 years old, it's going to be 92, right? The least acceptable is going to be 70 plus 2 times age. So the lowest acceptable normal blood pressure will be what? Come on, math whizzes. You know, when I tell you I don't care what the book says, I know that sounds cavalier, but I've written, a number of times I've written questions for National Registry. We go up there as a small committee and we write these questions. And I know these answers because I've been party to the writing of these questions. And every textbook is going to be a little bit different. I've had major parts of writing some of these different EMT textbooks. And every author comes at things a little bit differently. You know, medicine, they say practicing medicine because we're trying to get it right, but everybody does it a little bit differently. So when you look at ranges in one textbook, it's going to be different in another textbook. So sometimes I don't want you just to remember an exact amount of what your textbook says, because your textbook may say one thing and another textbook says something else. So I'd rather you learn something like this that can be useful for you rather than something that you're going to miss because you thought it was right and it really wasn't. So there you go. Y'all okay with that? Good. So that's what you get. If your patient is hoarse, when they're talking to you, they sound scratchy and hoarse, they may have a partial airway obstruction. And what would you do about that? Yeah, leave well enough alone. You'll transport, put in a position of comfort, give them some blow-by, leave well enough alone. Nasal flaring, we already talked about that, indicates respiratory distress. You want to count the respiratory rate before you ever touch them. Once you start manipulating them, what's going to happen? Yeah, they're going to breathe a lot faster, but what's one thing they also do once you start getting all over them? They start crying. Who can count a respiratory rate when they're crying? So respiratory rate is often done at the door. When you're walking in, you're doing your pediatric assessment triangle. If you got some time there, you might even have your partner say, you know, go ahead and get the respiratory rate while you're getting your stuff out or something. So you want to get that early. Looky there. You need to know the formula. Formulas. Is it formula? Common causes of shock in pediatric patients. Y'all can probably name these before I even show. What are they? What? Diarrhea and vomiting. Right up there. Infection. Trauma, especially abdominal injuries. Remember, in the adult patient also, as well as the pediatric population, you're not going to be shocky from blood loss from a head injury. You can't lose enough blood in your head to cause shock. So if they are showing signs of shock, what do we know? Probably blood loss somewhere else. Now, they could have a head injury and they've lost a lot of blood, but if they're going to show signs of shock, like a low blood pressure or something, it's not going to be because of the head injury. Allergic reactions. What is it about allergic reaction? What do we see in allergic reaction that causes shock? Vasodilation, that's right. I think on the last test, there was some confusion. We give epinephrine to allergic reaction to do what? Two things. Vasoconstrict and open the bronchioles. Because those are the two things. How are you going to know it's anaphylaxis? Respiratory distress and blood pressure drops. We fix blood pressure with epi, it vasoconstricts. We fix respiratory distress with epi, it relaxes the bronchioles, okay? So if you have a question about what that drug does, well, what are your problems? It's going to fix it. Poisonings also cause shock. Cardiac events, kids don't have cardiac arrest from dysrhythmias. You know, they don't have bad hearts usually. They haven't been smoking and eating crap for 100 years like we have. So pure cardiac arrest due to heart disease rarely happens. But you can have kids that have congenital problems, things that they're born with. Signs of shock, think of the pediatric assessment triangle. When you look at them, look here. Apathy or lack of vitality. They're listless. They don't move. There's not good, muscle movement. They're going to be breathing really fast at first, and then they don't breathe at all. Rapid pulse, weak pulse, altered mental status. This is when they don't make any eye contact with you. When they're not consolable, that's altered mental status. Their skin's pale, clammy. Absence of tears. These are the kids that, hadn't wet a diaper, hadn't changed their diaper in 3 days, and it's still dry. Delayed capillary refill. Now, we're not going to check a blood pressure on these kids, but at some point, if you did, it's going to compensate, and at some point, it's going to drop. So all these are going to tell you that your child is in shock. So look for them. Caring for the little old guys. What is that? Those don't seem to go together. Protect against hypothermia. Cover their heads, cover their bodies, keep them warm. Remember, they don't thermoregulate very well. You're going to have to turn the heat up in the ambulance until you're dying. Be very gentle with them. If they are hypothermic, you may check with med control to see if they want you to try to warm them a little bit more actively. But you should depend on them for that information. Hoarseness may indicate upper respiratory. Did we already do this one?
Mm-hmm.
Did I go backwards? Respiratory disorders. Most likely cause of cardiac arrest in a child other than trauma is respiratory disorders. But respiratory also factors into trauma. Da-da-da. Whoa. Cool. Cool beans. All right. You want to know if it's upper respiratory or lower respiratory. If it's lower, we're talking about what? Wheezing, something in the lungs typically. If you hear wheezing, sounds in the lungs, all the airway maneuvers is not going to fix that. So the only thing we can fix is an upper respiratory issue if they've got an obstruction. You got to be really watching so that you'll recognize signs of early respiratory failure. Early respiratory failure turns into late respiratory failure, which turns into children that don't make it. Anything here we haven't already? Listen for stridor. Stridor's an upper airway sound, okay? Wheezing, lower airway. Grunting, where's that? Upper, lower? Lower. Good work. If they're breathing more than 60 times a minute, they're in severe respiratory distress. Altered mental status. That's adults or kids. How you recognize an altered mental status in kid? Because they can't count to 10 backwards, How do you recognize an altered mental status? Yeah. Do they look at you? Do they make eye contact? Are they afraid of you? Are they grabbing mom? That kind of thing. If they are unresponsive to all of those things, they have an altered mental status, even if they're awake. Slow or irregular respiratory rate. Always bad. These are kids that are FTD. Cyanosis. FTD. Except when is cyanosis okay? At birth. Peripheral cyanosis is within normal limits, and they can remain blue around the edges for a couple of weeks after that as their body's going through some of those changes that occur. Central cyanosis is never good, but sometimes at birth cyanosis, peripheral cyanosis is okay. Decreased muscle tone. I think that's the phrase I was looking for a few minutes ago. That's going to be your dead giveaway. Decreased muscle tone. If they're just listless, if they are lethargic, that's never a good sign. Poor peripheral perfusion. How will you assess for that? Yeah, capillary refill. Decreased heart rate. Once they become bradycardic, they are in really bad shape. Oops, look what I have. High-pitched, squeaky sound in the upper airway. One more, come on now. Almost. Who put wheezes? You did? Just for fun? You just didn't want us to have 100%? Is that it?
Exactly.
I figured. Wheezes is going to be lower airway, stridors, upper airway. Ta-da! Okay. Differentiating upper and lower, y'all already know this. Upper airway, mouth, throat, larynx. This is where your foreign bodies are going to land. Swelling, if they've had burns or infections, stridor, difficulty breathing. Which is the following is a lower airway problem? Come on, one more. Who's not playing? Okay. Who put epiglottitis?
I didn't do that one.
I'd be embarrassed. Where is the epiglottis? Yeah, it's the very top of the airway. Yeah, pretty much. Right there, at the opening to the, above the glottic opening. So yeah, this is going to be bronchitis all the way. Irritation of the bronchioles. Lower airway, you're usually looking at the large or the small bronchioles or the alveoli. Of these, we use the asthma, pneumonia, other respiratory infections, lower airway. Wheezing is going to be your most common airway sound in these little guys. So when they wheeze, it may indicate any of these. So listen for wheezing. We're going to go through different airway disorders now. If you're keeping your little note cards, these are some things you want to put on there. Croup, most commonly viral. Why did I put this picture of the seal here? That's the way their cough sounds. Now, every time I try to do it, I go into a coughing fit. Who wants to make the seal bark sound? Somebody? Oh. Yeah. Oh, well, that was pretty pitiful. Okay. If making a chart here will help you, croup is a small word, right? It has a slow onset, low-grade fever, most common in younger kids. It's a little word, a little fever, little kids. Does that help you? That's going to be croup. It makes this characteristic seal bark cough. I'm going to have to embed that next time. You may hear stridor and other signs of respiratory distress. Croup. Treatment. If you have humidified oxygen, which in Alabama you should have humidified oxygen, it's a little tub of, a little bottle of water, and you basically thread your oxygen goes through there and comes out the other side and delivers to your patient. All right, epiglottitis. Epiglottitis generally is bacterial. See, big word, bigger word here. Older kids, big word, older kids, 4 and up. We've seen a resurgence of epiglottitis in the older population. We're actually seeing it less in kids now than we used to because they've got a vaccine for it that they're giving when they're young. However, a lot of your older people, age 20 and up, they've not had this vaccine, and so we're seeing it more commonly in older people. With epiglottitis, if you think about what happens here, if you've got an inflammation of the epiglottis, you know what the epiglottis is. That's that little thing that opens and closes when we what? Yeah, when we swallow. So remember we did this in class that day where I told you not to swallow? Remember? We were talking about epiglottitis then. So it's very painful when they swallow. So you'll notice that they drool a lot because they don't want to swallow. They have a high fever, usually 102 to 104. These kids look sick. So when you contrast the two, croup is, how fast does it come on? It's a slow onset. Fever, low fever. Age group, young kids. Epiglottitis, old kids, acute onset. I mean, they can be fine 9 o'clock in the morning. By 9:30, I mean, they're drooling all over the place. They've got a fever and they're sick and their airway starts to occlude. These are going to be, usually they're breathing through their mouth. It's painful when they speak. You'll see them in tripod position. Their chin's is going to bring the chin forward. Why is that? What's about bringing your chin forward? Yep, it helps open the airway. Just like when we do the jaw thrust maneuver, it opens the airway. In fact, if you ever have a patient, say that's atraumatic, say it's a cardiac arrest, a medical, they've had a heart attack, You tip the airway back and you're trying to ventilate them and you really can't get good air in. You're seeing air go in the stomach. Do the jaw thrust. It'll open that airway, slam up, and you should be able to ventilate easily. Inspiratory stridor, respiratory distress, changes in voice quality, all those epiglottitis. So make sure you know the differences between these two, because you're going to get a scenario and it's going to say, you know, Mrs. Jones called 911 because Johnny's had a fever for a couple of days and, you know, he's been kind of listless and he's had a cough. Which of these are we talking about? Yeah, you're not going to pick epiglottitis, right? Which of the following indicates croup? Would be an indicator. Number 13, sleeping. Okay, who picked the drooling thing? Drooling is what? Epiglottitis. Okay. Stop killing me. Treatment. Okay, if your patient has epiglottitis that we're talking about here, yeah. Don't put anything in the mouth. Don't look in there. What are you looking for? Nothing, because you're not looking in there. Don't do anything that might disturb your patient. You want to keep them very calm. Nothing that's going to freak them out, because what happens with epiglottitis, that just continues to get worse. And if they get freaked out, or if they start to stress or constrict their muscles, it may actually cause that epiglottis to freeze over the glottic opening or swell so much that they can't breathe at all. In fact, in the field, we don't intubate this patient until their airway is completely blocked. You know, as long as they're moving air, we're leaving well enough alone. So we don't want to do anything that could cause a spasm and block the airway. Position of comfort, non-rebreather or blow-by, whichever you can manage easily without freaking the patient out. If I've got a patient that's showing signs of epiglottitis, you want to go ahead and call for ALS backup. Because if this is serious and it's progressing quickly, then they're probably going to need to be intubated. Fever. If you've got a patient with a fever, is fever common for little kids? Yeah, you bet. To cool them off, you can remove some of their clothing. Why would we put a towel, a wet towel on them? Yep, body loses heat 25 times faster when it's wet. So you wet them, they're going to cool quickly. You do have to be real careful about not overcooling them. If you leave that towel on them until their temperature gets normal, then you pull it off, their temperature is going to continue to drop another point or two before they rebound. So the temperature of the body doesn't keep up with the speed of which it's releasing heat. So make sure you don't overcool them, then they're going to start shivering. You may consider some ice chips or water if they are alert and oriented and they're able to do that. Don't dunk them down in cold water. Cool water is the name of the game here. All right, question. Which of the following presents with increased mucus development? Let's see if you read the chapters. Let me check that in my book. One more. Oh, he's in the bathroom. You're right. Okay, let's see. What do you think it is? I got it right. Asthma, yeah. We talked about this earlier in the semester. You get a lot of mucus that builds up in there, and it's hard for that to clear.
The asthmatic,
You're asthmatic? Yeah, you got that right. Okay, yeah. Epiglottitis doesn't cause mucus buildup. Bronchiolitis, not so much. Asthma is what we're looking for here. Asthma, so this should be on one of your note cards so you can recognize it. Inflammation will produce mucus. It causes constriction of the airways. That's how come you get that wheezing sound. The airways also start to swell. So you got several things going on. You get a buildup of mucus. The airways swell. That's kind of what causes that whistling sound. The air comes in easier than it goes out. It kind of slides in, but you have to kind of force it out against that pressure. and it causes that wheezing. Smooth muscles contract, and the airways will narrow. So can you think of a medication we could give that might help relieve this? Yeah, and I mean they may take a bronchial dilator, but it will do some of this. But if we've got a severe asthma attack, the ALS level, we're going to give them epinephrine because it allows a smooth muscle tissue to relax. The wheezing because of the swelling there. Here we go. Here's a little picture of this. Signs and symptoms of asthma: shortness of breath. They're going to say their chest feels tight, wheezing. Children more commonly than adults will report a non-productive cough. How is that cough helping them? It what?
Trying to break up the stuff.
No, it's a non-productive cough. They're not bringing anything up here. What's coughing doing for them? Develop that.
They're changing the fluid out into those.
Yeah, it's not that they have the fluid so much, but it's kind of like grunting. The little kids grunt. They get a little bit older, they're going to cough. That coughing acts as back pressure, like PEEP, and it kind of helps to keep your alveoli inflated. Treatment, it's going to be just about the same. Humidified oxygen, if you have it. Non-rebreather, if they have an inhaler, you want to use it early. If they've already done, 15 puffs, is a few more going to help them? No. If it hadn't worked after a couple, it's probably not going to work. But asthma is one of those. There are really two different actions going on here. If you can get it early and treat it with the inhaler may help, but it's not going to be a long-term. That's why they've got they call it a rescue inhaler, but they also take medications that help keep this inflammation down, that helps to keep the buildup of the mucus down.
Basics aren't allowed to give nebulizers, are they?
I'm sorry?
So basics aren't allowed to give nebulizers, are they?
No, but they do give it at the advanced level, so that's good. Bronchiolitis is a viral infection of the bronchioles. Nice little picture there. Bronchiolitis typically is going to be in a young child up to about 2 years of age. That's where we see it most commonly. And it's also can be fairly severe when they're young. Presents like asthma. I have a low-grade fever associated usually. They're usually going to be breathing fast, trying to get some air through. Heart rate picks up, shortness of breath. I don't know how they can tell a kid who's 18 months old has chest tightness, but we do see it. You can see it a little bit older, and they may report that, but it's hard to assess that on a child. But wheezing would be, like it says up here, it's presents similar to asthma, so you'll see a lot of the same signs and symptoms. But what's going to be the difference here? How are you going to differentiate this from asthma? Fever, yeah. And children can tolerate a higher fever than adults can. 104 fever for any of us in here would be a significant fever. 104 in a child is just getting good, just getting going real good by then. Treatment, let's see, humidified oxygen, airway delivery, position of comfort. What's going to be the position of comfort for these kids? Yeah, any respiratory distress? 9 times out of 10, they're going to want to sit up. If they're laying down, what do we know about them? Yeah, they're beat. They're too tired to sit up. They can't sit up. Pneumonia. Viral pneumonia results from a spread of infection along the airways. Signs and symptoms: shortness of breath, chest tightness, diminished breath sounds, dry, hacky, non-productive cough. Providing back pressure in there. It's helping to split the airways open. Am I missing one in there? Let me go back. Yeah, and little kids, let me see. What are we talking? Little kids with pneumonia very frequently will lay on their sides and they'll pull their knees up. It kind of helps take that pressure off of the chest. Because sometimes they may have this pleuritic pain. Pleuritic pain is going to be due to the lining of the lungs as it moves within the chest cavity. So if you bring the legs up, there's going to be less drawing because there's not as much stretching in there. So they're going to be more comfortable frequently laying on their sides with their knees up. What other patient population or disorder do we see where they like to lay and pull their knees up? Abdominal pain. Good work. Okay, pneumonia. Usually it's going to be a secondary infection. They've been sick from something and then they get pneumonia, fever, cold, something of that sort. Your treatment? Oxygen, some type of airway delivery, position of comfort. Meningitis. Meningitis can turn bad very quickly, so you need to be alert to the signs and symptoms. Anytime you got a little bitty kid, less than 3 or 4 months of age, who has a fever, they're always going to do a spinal tap. They're going to be looking for meningitis because kids that age, under 2 months of age, they just don't get a fever. So if they get a fever when they're really young, then they're going to be worried about meningitis. If they've had an ear infection or upper respiratory infection, that may be part of it. High fever, lethargy, irritability, vomiting. They may have a rash. Probably a third of the children may actually have a rash as part of meningitis. But one of the things they'll tell you is they got a really bad headache and it hurts to move their neck. So if they've got a fever, they're real cranky, with or without a rash, that's one of the things you want to ask them. Can you move your head okay? If they go, no, it hurts, then I'm all about the meningitis thing. Rather be safe than sorry. Usually it's spread by close family contact. We see it, populations that live close together, dorms where everybody shares the same kitchen, that kind of stuff. But not just by casual contact. Bacterial meningitis, while it's rare, it's also serious. We see it in the very young as well as usually older population. Viral meningitis we see it more commonly, but it's usually a little bit less serious. So of the two, bacterial meningitis is more severe, but less common. Treatment, let's see, ABCs. Do you want to give humidified oxygen? Everybody else gets it, might as well. You may have to ventilate them. Of course, if they get into cardiac arrest, you're going to do CPR. Why do we see an uptick in seizures in patients with meningitis? It could be the high fever, but that's not typically why we see it. But yeah, they've got an inflammation of the lining of the brain. And as that swells, it may present just like a head injury. Head injuries, you see seizures frequently. So yeah, this may present like a head injury except for the stiff neck issue. Okay, what's the most common cause of dehydration? I'm freezing in here. I turned that back when I got in here. One more, come on now. Hey! Whoa! Vomiting and diarrhea in a little kid, you just wouldn't think it, but dehydration is extremely common. If they've been vomiting, the smaller they are, the less time it takes. If they're 5 years old, it might take 2 or 3 days. If they're 6 months old, it might take 6 or 8 hours. So always be alert to signs of shock. How would you recognize shock in a 6-month-old? Here, I'm going to help you out. What are they going to look like? Crap, yeah. My teacher said you'll look like crap. Probably shouldn't say that, but I do. Yeah, you're going to look at your pediatric assessment triangle. They're going to be lethargic. They're not going to make eye contact. Their skin's going to look bad. They may or may not be breathing normally, but you would probably expect it to be a little bit fast, right? All right, so look for signs of shock. Pay attention for it. If they're not interactive, they're not moving, and they're a little kid, something's wrong, don't you think? I mean, do you ever see them sit like little statues, not looking at you? No. Seizures. What's the most common cause of pediatric seizures? Pediatrics. Fever. Yeah, what do we call those? Oh. It's fever induced, so it starts with an F. Febrile. Febrile seizures is going to be a seizure from high body temperature. We see this most commonly kids under about 5. If you've had one febrile seizure, chances of it happening again are pretty good. The tip-off to a febrile seizure is not how high it gets, but how rapidly it gets there. So if you get a kid that goes from 101 to 104, remember I told you 104 is not a lethal fever, but if it goes from 101 to 104 in 5 minutes, you run a great risk of seizure. If it goes from 101 to 104 in 3 hours, you know, hey, you got a fever. But it's the rapidity of the spike. It's not how high it gets. So if a kid sneezes, just make sure the airway stays open. You don't want to try to restrain them in any way. Don't put in an oral airway. I was watching something the other day. Said, put something in their teeth so they don't bite their tongue. Really? No, we don't do that. Put them on their side if that's okay. Why do we put them on the side? In case they vomit, it'll go out. Gravity will take it down. Watch for vomiting, oxygen transport. Altered mental status in a kid is never good. Watch for a mechanism of injury to make sure it's not trauma. Watch for signs of shock. Poisoning is a very likely cause of altered mental status. But also get history from the parent. You know, are we looking at diabetes as a possibility? Find out if they have a seizure disorder. So with altered mental status, it's just like with an adult. You got to go down that whole list of things. Do y'all remember that sheet I gave you for altered mental status? I hope I gave it to you. You move so fast in the summer. I may have given it to you and I forgot to tell you what it was. I just can't remember.
I don't think you did the sheet. I think that's just a slide on the screen.
Does that look familiar? AEIOU tip. Anytime you get a patient who has an altered mental status of unknown origin or coma of unknown origin, you want to go through this list of things. I hope I can remember them all right now. Of things that could give your patient an altered mental status. Can you think of anything that starts with A that may do this? Nope, that's not it. What is it? I gave y'all a sheet, remember, with the sample on it and all that stuff? Yeah, y'all pull it out.
Acid, that's alcohol, beta acidosis too.
Oh, no, it's not ETOH, it's epilepsy. Hang on. Yeah. I is insulin or infection. What's the O? Uremia, what's that? Yeah, probably septic or something. T is trauma. I, got 2 I's. I'll put both of them over here. P. Is it sepsis?
Stroke.
Huh?
Stroke.
Oh yeah, that's good too. I guess sepsis is uremia. Yeah, so if you got anybody that's unconscious, now you're not going to look for stroke with a 2-year-old, right? But they could be acidotic. Which patients do we see acidotic? What do you think, Peyton? Do what? Yes, renal failure. Diabetes, yeah. If they have DKA, diabetic ketoacidosis, they're going to be acidotic. Could you have a 2-year-old who's epileptic? Yeah. Insulin, could you have a diabetic? Mm-hmm. Overdose? Yeah. Uremia? Possible, not likely. Trauma? Yeah. Infection? Psychosis? Probably not yet. We haven't ruined them yet. Stroke? Probably not. But some of it's going to be age dependent. But those are the things you're going to look at and think of if you have anybody with an altered mental status. You know, no matter what healthcare profession you're in, whether you're a parent or not, you got an altered mental status. The kid's 13 years old. You've got an altered mental status. What are you thinking about? Stroke? Probably not. Acidosis? Maybe if he's diabetic. What are you probably going to be looking at? I'm looking at overdose probably. Okay, so altered mental status. Look for the mechanism of injury. Go down your AEIOU tips. See if you can figure out what it is. Look for signs of shock. Remember, pre-hospital, we're concerned about A, B, C, right? And then our mental status. That we're looking for what's going to kill you, not for, you know, what's going to kill you 6 months from now. Get a history if there's any history of diabetes or seizure disorders. Any poisoning, we're going to consider activated charcoal. You're going to think about it. You may think about it on National Registry. We don't give activated charcoal in the field here in Alabama anymore. Everybody gets oxygen, and then you're going to do your reassessment. When you do a reassessment, according to your sheets, what do you start with? You're reassessing. Yeah, that's also known as what? Your primary survey, right. Remember, what are the first 3 parts of your primary survey? General impression, mental status, chief complaint or mechanism of injury. Good work. And then ABCs, right? And then after that, going to be your transport decision? Is that what you said? Okay. Good work. The patient's unresponsive, poisoning patient, you got to maintain the airway. It's going to be ABCs all the way down the road. You may have to artificially ventilate them. If they're unconscious, you got to try to rule out trauma. Could they be unconscious from a trauma and have been poisoned? Yeah, could be. Drowning, you may have to do CPR. You may have to just ventilate the patient. It's possible that they still have a pulse, they're just not breathing. With a drowning, you need to look at the circumstances and see if you need to spinal mobilize a patient. These people are wet, right? They've drowned. That happens only when you get wet. So make sure you protect against hypothermia, that you dry them off and keep them dry. Manage. Yeah, but dry drowning doesn't mean that they've stayed dry. When they talk about a dry drowning, they're talking about the lungs are dry. And that'll be a function of the salinity of the water that they've ingested. Well, that's part of it. Sudden infant death syndrome, SIDS. The definition, sudden unexplained death of an infant, and they're not able to determine why. Unless there is obvious death, rigor mortis, you want to go ahead and attempt resuscitation. Most of these deaths, they're unattended, nobody was looking at the baby and they stopped breathing. And there may be a time where you may be able to resuscitate, but most of these, they just immediately go in cardiac arrest. You know, it's respiratory arrest usually causing cardiac arrest, but it's not like a trauma where kids have, you know, where the parents have seen them falling off the roof or something like that. So go ahead and resuscitate, even though you know it's not going to be successful, unless they're like blue all over or they've been dead for several days or something. But just like we were talking about when you deliver a baby, you know, you're better off resuscitating unless you look really stupid because the baby's obviously dead. Peak age of SIDS death. I almost told y'all this. I'm glad I did. Yeah, 2 to 4 months is going to be the peak age. It's almost non-existent after 12 months. If you've got what appears to be a SIDS death, if you've got a baby that's dead, they're under 1 year of age, you got to look at it like a crime scene. So consider that. And I'm not talking about accusing anybody. Could it be a crime scene? You bet. Until you've seen one of these, seen shaken baby syndrome, then you'll know these can be a crime scene. So just because they're in cardiac arrest, don't just automatically assume that it's SIDS. So look at your scene. Look at your baby. You know, remember what you've seen. See how the parents act. So consider that. Attempt aggressive resuscitation unless they're obviously dead. Should you allow parents to watch a resuscitation? You vote on this one. That'll creep you out, won't it? Let's see. Come on, we take a couple more here. I'll take a couple more answers. Did we lose a whole bunch of people here? Okay. Interesting split. Yeah, the documentation says yes. They say that the family recovers better if they've been able to see it and they know that you've done everything possible. And that's why we say, unless they're very obviously dead, then go ahead and attempt a resuscitation. That way you set their mind at ease. Everything that could possibly have been done was done. So you don't want them second guessing, say, they should have tried. Why didn't you do this? You don't want them to sue you. You know, if the baby's passed away, now the parents or the caregivers or whoever there, those are going to be your patients. So cardiac arrest in kids. You should know this. At what heart rate should you begin CPR for a child? Come on. I always got a couple slow ones in here. Wake up. Wake up. One more. At which heart rate should you begin? It's 60. If it reaches 60, you're going to start CPR on a child. So start compressions when the heart, well, actually less than 60. If they're unresponsive, there's no pulse, they're cyanotic, they're not moving, this is not heart disease here. They got something going on. You'll start bagging them, you'll do CPR, you'll use the AED. What do we call that part of an AED that reduces the energy level for a child? I told you guys, you just forgot. Okay, think back in your brain, see what you can remember. Is this looking familiar? Is that how you spell it? Look okay? A dose attenuator. That means it reduces the dose. It reduces the energy level. So you may have what appears to be an adult AED, but it may have a dose attenuator on there. Maybe a switch, or maybe you have a pediatric AED where the dose is going to be reduced. I tell you that because I argued with somebody at registry about using that word, and he said, EMTs should know this word. So please know it. Dose attenuator. All right, pediatric trauma emergencies. Trauma is the #1 killer of children age 1 to 14. 50% of trauma deaths occur within the first hour of injury. Why is that? They compensate and then they fall off the cliff. Usually this is going to be a result of shock where they bled out. Usually an abdominal injury because they're not perfusing. All right, consider both the mechanism of injury but also consider the different anatomy of the pediatric patient. You know, some of those things we talked about, you know, where their organs are. As I mentioned before, they may be severely injured and they won't show any signs of it. So they compensate so well you just can't believe it when they fall off the cliff. Injury patterns. Unrestrained kids in the car, you know, we don't see it very much anymore. When I was raising my kids, we still saw it all the time. But you do see it. How are they, what's going to happen to them if they're unrestrained? You know, you got a 3-year-old standing in the back seat. Yeah. You know, if somebody stops in front of them, they're going to go head first, flying right for the windshield. So you see a disproportionate amount of head and neck injuries because of that giant head. They can hit anything inside the car in that event. If they're restrained, and all that does, the restraint systems just keep the child from being flung out of the car or being flung around the inside of the car. But they can still have abdominal injuries, you know, back injuries from the restraint systems. Now, kids are different than us, and I can't remember if I mentioned this to you. When a kid, on a bike or walking, when they see they're about to be hit by a car, what do? They're so curious, they just look at it like this. They turn towards the car and get hit very frequently on their front part. What do you do if you see a car coming at you? Yeah, so we're more likely to be struck from the back. So kids much more commonly are going to get that head-on thing, which is going to be more serious for them. If they're riding a bike, think about where they're going to be if they're riding a bike. That lowers them a little bit. So depending on the size of the car, you're going to look for different injury patterns. So if they're riding a bike, head injury, spine, because it drops them down so they're close to the front of the car. You know, if a car hits me, a low car hits me, it's going to break my leg, right? You know, I'll just walk on off dragging my leg. But a little kid gets hit and they've got, you know, this part of their body that's going to be more likely to be injured. If they're injured while diving, like swimming, diving, suspect neck and spinal injuries, always. All right, pediatric injury patterns. Ooh, this is long, isn't it? Head injuries, because their heads are so big, it's going to be propelled forward. It's going to be the first thing to hit lots of times. Chest injuries, the ribs are pliable, so they spring in, do damage, and spring back out. You may not see any evidence that that's occurred. Abdominal injuries, they have very little protection around the abdomen, so you can have a lot of bleeding there. If your patient is deteriorating without signs of injury, suspect hidden abdominal injuries. And I'm saying this, I worked at a pediatric hospital, and I cannot tell you how common that is. You know, they look fine. Everybody thinks they're great. And then they just start deteriorating, and they find that they were bleeding out in the abdomen. Burns, children, this should have been less than 5, suffer more severe consequences from burns. Hypothermia, fluid loss. If you got a burn on a little kid, consider it serious. Spinal mobilization. You got to spinal mobilize kids because of the size of their head, they run a great risk of having spinal injuries, but it can be very challenging to do that. So package them, oxygen, just like you would for an adult. What should be used to immobilize a 3-year-old? Which of these?
Oh my God.
How'd y'all vote so fast? You didn't even read it that fast. Holy cow, if y'all miss this, we're in trouble. Whew. Thank you for that. That's what they look like.
Yeah, no, that's like it actually fits. It doesn't ever fit people or like trying to use it on.
Yeah, well, it fits kids real well. Removing a child from a car seat, y'all can read about that. They say that, you know, you want to take them out of the car seat. Take the car seat out. If it's a small car seat, take it out, lay it down on the board, and then slide them out that way. Make sure you put the seat collar on, slide the child out of the car seat onto the backboard. Pad under them, you know, make it as comfortable as possible. Recognize that you may have a problem with the head, right? The younger they are, you're looking at a big old head that's going to disrupt the inline stabilization. How are you going to correct that? You're going to pad under the shoulders, that's right. But don't pad just because I said pad. Look at the way they lay and pad so that you get a neutral alignment. Burns, as you do for any burn patient, you doing? Cracking your knuckles?
Uh-huh.
Oh, it creeps me out. Remember with burns, dry sterile dressings, not moist dressings, dry sterile dressings. Watch for airway burns. You guys have learned this little thing? Look back over it. 18 for the head. The arms are 9, just like ours are. What's the difference in the legs? Our legs all the way around are 18. Their legs are 14. That's right. Indicators of abuse. You don't need to take a break again?
And how, no.
I don't know where we are.
We go,
Keep going.
we're 125.
Oh, yeah, she's got
You know
them.
that? You can see that? Oh, you got them all printed out. Okay. How many are there? 150? Okay, we're close. Okay, ways that you may recognize. What'd you say?
Who?
Him. I can see.
Nobody
You-
said, they're laughing because every time I take another one. And that's the reason why.
Okay. Abuse indicators. Anytime you see bruises in multiple stages of healing, odd injuries in different kind of places, broken bones, of course, are always red flags. Are they always abuse? No. But it is a greatly increased the likelihood of that. Injuries on the front and the back side of the body, usually don't fall and like roll around and get bruises everywhere, but that may indicate something. Where the iron has been burned on the back, that doesn't happen randomly. So look for things that you know don't fit what you've been told. Injuries to the genitals, very unusual for that to happen in a normal way. Injuries, shaken baby syndrome. Anytime you've got a young child who's unconscious, you immediately want to think about shaken baby syndrome. Untreated chronic illnesses. Just because a child hasn't been beaten, that doesn't mean that he's not being abused. So you want to look at the environment also. If you got a child that is malnourished, that sort of thing, unsafe environment. If you go in and there's drug paraphernalia, then there's a problem there with a child that's not being cared for right. So these are all things that you have to report. It's mandatory reporting. Sometimes you may have, you can see a child that's got bruises in several stages, or you can see an injury that happened several days ago and they didn't call. That's one of the things we see with a shaken baby. Sometimes they don't call right away because they're hoping the baby's just falling asleep, it's going to wake up, and it doesn't happen. So look for things that don't fit the pattern. A 6-month-old pulling a hot pot off the stove. Now, why is that unusual?
They're not saying how.
Yeah, they're not tall enough, but they ain't walking. They're not even crawling. So for something like that to happen, it didn't happen that way. Burns on the bottom of the feet, how did that happen? Yeah, it looks really bad. I hate that. Look for physical and sexual abuse also. Bite marks, burn marks, they ripped the hair out, broken bones. They know how to investigate that at the hospital, so they can figure that one out. We can't. Your main concern is going to be what? The child. So whether the child really is injured to the point that they require hospitalization or require transport, you're going to transport them because why? Yeah, the safety of the child. You need to get them out of that environment. For the adults in the area, if they show inappropriate concern or non-concern for the child, they may carry it overboard, or they may not have much concern at all. If they're very angry, that may indicate they have some anger management issues. Alcohol, drug abuse, suicidal thoughts, all sorts of those may be possible indicators that an adult may be an abuser. If you get a call for a child who may be abused, get law enforcement involved if you need to. If you can get the child out of the home and transported, that's going to be your best option. You're going to report it anyway. Get the child out of the environment. Do a good job of examining the child and do a good job of documenting it. If you've got child abuse going on, there's a good chance you're going to go to court with that. So you want to make sure you have a very thorough run report that documents everything. So in order to do that, you need to do a good head-to-toe exam. You want to get a history from the caregivers, but you also would like to get a history from the child away from the caregivers. They don't need to be hearing the story. So if you can separate them and get a good history, that should be maybe very interesting for you. Don't leave them alone with somebody that you suspect as a child abuser, and then document very well. Children with special challenges, we're seeing children that get well enough or treated enough that they're able to go home. In the olden days that didn't happen. So we're seeing children that are much sicker now, just as we do adults. We see that they're much sicker. If you have premature infants, that's one of the problems we have delivering kids that are premature, is their lungs are not well developed. How are we going to manage a baby if we're running and they have respiratory distress? We're going to manage their airway like anything else, right? We have kids with that may have heart disease or disorders, usually not heart disease, neurological diseases or disorders, congenital. Here's a question for you. The tracheostomy tube is located in the come on. We're all waiting on you. Oh, come on, last one. Okay, good. Okay, tracheostomy. What does that sound like? I'm not going to ask who put those other things. Tracheostomy tubes. Problems with the tracheostomy tube. They may become obstructed. What's the most common cause of obstruction in a tracheostomy tube? Secretions, snot, yeah, that kind of thing. It may bleed. It may get infected around there. There may be some air leaking around the tube, infection, it may be dislodged. A lot of these things we can manage. How are we going to manage an obstruction? Suction. Bleeding? Yeah, we can control bleeding usually. Air leaking around the tube, you may just have to fit it down a little bit better. Infection? Not a lot we can do about that. Dislodged tube? Slide it back in. Usually just slide it back in. Here we go. Just a photo. Okay, home ventilators. We have kids on home ventilators. Who's going to be your best resource if you have a kid on home ventilator? The caregivers, certainly. Central IV lines. Central implies what? Central as opposed to peripheral. So if it's a central line, it's not going to be out here somewhere. It's going to be here in the core. Care for patients with gastrostomy. I can't talk tonight. Tubes. They have a tube in there. Where would that be? Stomach. Okay. Watch for altered mental status, airway, suction, all the usual stuff. Oxygen. Usually they're going to be transported sitting up, or they may be on their right side for transport. Question. The AV shunt. Which of these is true regarding an AV shunt? Come on, one more. Somebody's scared. There we go. Only 3 choices. What about that check mark? That's wrong. That's wrong. An AV shunt drains cerebral spinal fluid. It connects the brain, has a tube that runs down to the abdomen, located in the heart. Who put that? I have to go back and check all these things. Yeah, if you get a patient that develops that their body creates more cerebral spinal fluid than it needs, if it stays in the brain area, then it's going to like explode your head. So, not really. But they're going to have to drain that, and so they're going to have a tube that runs down into the abdomen for it to drain. So you can imagine what would happen if that tube gets blocked, right? What's going to happen? Yep. Do you have a question, or are you going to answer?
I got a question.
Okay.
Is an AV shunt different than an AV fistula?
Definitely. An AV shunt is going to be a tube that's going to connect these 2 items. With the fistula is going to be for dialysis. It's going to connect the atrial and the ventricular system.
Okay.
Here it's just draining cerebral
I didn't
spinal
know if
fluid.
they were interchangeable words or something like that.
No, here, it's just like atrial ventricular, we've got ventricles in the brain, and that's kind of where that derives from. But anyway, that's going to be draining CSF. That was a question from Registry last time. Care, I already talked about that. Airway, there's really nothing we can do to clear that, but recognize that they may present like they're having a stroke. They start out with a severe headache. They may have an altered mental status from that. Nothing we can do about it except rapid transport. Psychiatric effects, treating children is very difficult for us. 10% of our runs involve pediatric patients, so it can be very disturbing for us for a lot of reasons. They're very stressful. You've got young kids. You may identify with them. It makes you very nervous dealing with them. If they are very sick or they die, you know, we feel that very acutely. You practice communicating with little kids. You got some around you, it can be kind of interesting. Be careful that, well, what do we got here? Most of the time, you treat a kid like an adult. There's probably 20% of the time where it's going to be different. So your approach is going to be different. You're going to have different outcomes, different causes. If you do have a bad call involving a pediatric patient, talk to other people about it. Get some perspective. Look where we are, see? Things to remember, pediatric assessment triangle. You're going to have to know that. See how the caregiver, y'all just hang on or we're going to stay here all night. Okay, I know this is challenging for you, but let's be professional in here, okay? There we go. Remember, be cognizant of their different anatomy and physiology and their psychosocial development. Gee, our treatment is still going to be ABCs, right? Care for shock, prevent hypothermia, you'll be okay. Shock is subtle. You're not going to recognize it. So what are you going to base your treatment on? Mechanism of injury or what? Nature of illness. Don't wait for signs to appear. Treat early and often. Given certain situations, how would you involve the parent or caregiver in treatment? Where was I going with that? Can't remember. Okay, you're called to the home for a 3-year-old child who's been running a low-grade fever all day and is now drooling. As you enter the patient's bedroom, you hear what you think is a seal-like bark.
Oh, that's weird. But drooling, low grade is still bark, that's crude, but the drooling, that's.
What do you suspect is wrong?
Respiratory problems.
Yeah, so we've got a low fever.
It's younger.
It's not acute. He's had a fever all day. Young kid, seal bark cough. He's probably just a drooler. What do you suspect is wrong? How are you going to handle it? How are you and your partner going to treat this patient? Humidified oxygen, O2, and transport. Isn't that a cute little picture? I love that. Now you recognize that on Thursday we're having a test downstairs. Tomorrow night, what's happening tomorrow night? You're checking off on trauma if you haven't already. Y'all can just wait. You can just wait because I think I might have another quiz. I feel a quiz coming on. So tomorrow night we're checking off on trauma, and if you're ready, we're checking off on medical. And for those of you that missed something, of which there are a few, your makeups are going to be tomorrow. So a couple of you may have missed splinting, you know, the 2 splinting things. Yeah. You missed KD. Somebody else missed. Was it you? Gone? You didn't miss anything when you were gone? Where'd you go? You didn't go anywhere. Anyway, I've got Kenyon, KED. Huh? Yeah, I have it on you. You haven't done KED. Okay. Back there, yeah. You missed splinting. Yeah, somebody else missed splinting. Anyway, so y'all going to make those up tomorrow night, all right? And We're doing labor and delivery tomorrow night, so you're going to be delivering babies, so refresh that. But I want this to be your very best test score on Thursday night, all right? So you don't have to wear your uniforms tomorrow, but please dress respectfully. See you tomorrow. For those of you that haven't registered for National Registry, we're going to do it. Here. Don't forget to turn in your little hickey doos. Huh?
I thought they said they wanted to register for that.
Oh, yeah. And tonight. Let's do it tonight.
Oh, I'm still in.
Okay.
It's really not that hard to look at this sheet. I just know
You ain't gonna be done. You wanna leave and go home, Freddie? You gonna do it?